Welcome class to chapter 9 on articulations or joints. An articulation or joint is the place where any bone meets another bone, cartilage, or teeth. And these articulations can vary in how stable they are and how mobile they are. So how strong they are of a joint and how well they can move. And they're classified into categories based on those two qualities, stability and mobility, and it's determined by the joint structure. And if a joint is more mobile, it will be less stable and vice versa. And this makes sense if you think about your shoulder, your glenohumeral joint, or your hip joint, that ball and socket joint. Those are very movable body parts. You can move your shoulder all the way around and you can move your legs very well. So because they're very movable, they're usually the least stable. So you'll see a lot of injuries in the shoulder and the hip. Then the elbow is kind of right in the middle. But once we get to intervertebral joints, and especially the sutures, the joints between the skull bones, those are completely immovable. So because they can't move at all, they're directly connected to each other, immovable, they are the most stable. So classified by structure, joints can be fibrous, cartilaginous, or synovial joints. Fibrous joints are where bones are held together by dense regular connective tissue. Cartilaginous joints are bones joined by cartilage, and synovial joints are bones separated by some sort of fluid-filled cavity, like your knee or your elbow. Classification by function, we get some Rose's words, and they're kind of confusing here, but you should know these differences. A synarthrosis joint is completely immovable, so an immobile joint. An amphiarthrosis is slightly mobile, and diarthrosis is freely mobile. So if you can remember the acronym SAD, SAD, synarthrosis, amphiarthrosis, and diarthrosis. S is the completely immovable one, slightly movable, and then freely movable joint. So here are fibrous joints. An example are gumphoses or a gumphosis, which are the joints between your teeth and the maxilla bone and the mandible. So this is a synarthrosis, completely immovable. Sutures are joints between the skull bones, also synarthroses, immovable. And syndesmoses are joints between parallel bones, such as your radius and ulna in the forearm and your tibia and fibula in the lower leg. And these are amphiarthroses, so they're slightly movable. And these joints keep these two bones held together when you turn your forearm facing posteriorly. Cartilaginous joints are bones attached by cartilage. We have synchondroses or symphyses. Synchondroses are bones joined by hyaline cartilage, and they're synarthroses, so completely immovable, and symphyses are bones joined by a pad of fibrocartilage, and these are amphiarthroses, slightly movable. You can see examples of these. The pubic symphysis holds your two pubic bones together. That will actually soften and separate during labor, delivery, and late pregnancy to allow a baby to come through the birth canal. And also an intervertebral joint are symphyses, both containing fibrocartilage. Synovial joints are freely mobile diarthroses. The articulating bones are separated by a joint cavity, and we have these structures of the joint cavity that you should be familiar with. The articular capsule is made of two layers, an outer fibrous layer and an inner synovial membrane, which will secrete the synovial fluid that will fill up the joint cavity. So here's a look at the synovial joint. More anatomy of it, the joint cavity is the space between articulating bones. It will contain the synovial fluid. It will help lubricate and nourish the cartilage and nourish the chondrocytes of the articular cartilage and help to absorb shock during compression of the joint. The articular cartilage itself that covers the ends of these joints just helps to reduce friction and act as a shock absorber. Synovial joints also have ligaments that connect bone to bone. These strengthen and reinforce the joint capsule, and then it also has sensory nerves and blood vessels to help nourish tissues in the joint. More accessory structures, we have bursa or bursae. These are sacs outside of most synovial joints where ligaments, muscles, tendons, and bones rub. They'll contain synovial fluid. Tendon sheaths are elongated bursa around tendons, particularly in your wrist and ankle where tendons rub together. And then fat pads are just extra packing material that help to provide some sort of protection. So here are bursa and tendon sheaths. You can see the tendon sheaths around the tendons in your fingers. And you can also see the bursa providing extra support in the knee joint here. So everything, a bursa or a tendon sheath, is in blue. Angular motion. These are motions that increase or decrease the angle between bones. So we include them in the joint chapter because joints move your bones and angles describe the type of motion that these joints will make. You should be very familiar with all of these in this list because as you go into your healthcare related fields, you'll probably be reading notes or patient charts that have words like this in them. Flexion and extension. Flexion refers to any time you decrease an angle between a body part or a joint. Extension is to increase the angle. So if you perform a bicep flexion, you're bringing your forearm up to your brachia, your upper arm, and extension would be bringing it back down. So flexion is always decreasing the angle, and extension is increasing the angle. We can see different examples of flexion, extension, and hyperextension. Again, it's important to note that these will all be referring to someone in anatomical position. So remember, in anatomical position, palms are facing forward. So flexion would be bringing your toes up towards your nose, and extension would be kind of pulling your fingers back. And flexion and extension of the knee, flexion of the knee would be bringing the knee up, and extension would be bringing it down as if you were kicking a soccer ball. Then we get to some lateral flexion, which would be flexion decreasing the angle to the lateral side. Abduction and adduction. Abduction, to abduct a part of the body, is to take it away from the midline, and adduction is to bring it back to the midline. So abduction, think of abducting, and adduction is to adding it back to the midline. So this leg is being adducted, abducted, taking it away from the midline, and adduction is bringing the leg back to the midline. Circumduction combines kind of all these flexion and AB and adduction all at the same time as you go in a circle around a midline. So this is circumduction. And this is an example, some more. A bone turns on its longitudinal axis. Examples of this are the atlantoaxial joint, which turns back and forth in the no gesture. Limbs will also turn to and from in the median plane, whether they laterally rotate or medially rotate, and whether they pronate or supinate. So you should understand these. Rotation is rotating around a central axis. Laterally rotating the arm would be bringing it out laterally, and medially rotating the arm would be bringing it back across the body. Laterally and medially rotating the leg can also happen if you laterally rotate the leg out and then medially rotate the leg back in. So laterally rotating the ankle would be out to the lateral side, and medially rotation would be out to the midline. Pronation and supination are incredibly important because many people break their arms. So their notes, if they're trying to heal from a broken lower arm, whether it's the radius and tibia, will describe if they can pronate or supinate. Remember, anatomical position would be in supination. So anatomical position would be as if you're holding soup in your cups in your hands, and pronation would be moving your palms to face posteriorly. So supination would be moving the forearms forward, the palms facing forward, and pronation would be moving the palms facing backward. Special movements, we have depression, elevation, dorsiflexion, plantar flexion, inversion, eversion, protraction, retraction, and opposition. Many of the muscles and bones and structures that you guys are learning in lab might have an elevator or elevation name, part of its name, and that'll help tell you what it does. Dorsiflexion, there might be some things that have a dorsiflexion component to it, or plantar flexion. So depression and elevation, we often refer to your scapula. If you elevate your scapula or your shoulder blade, you're shrugging your shoulders up, and depressing your scapula, you're pushing them down. Eversion and inversion. So this is someone, you can see here, it's the same, it's their right foot. Inversion would be curling the toes towards the center, An E version would be kind of curling or moving the ankle out towards the side. Dorsiflexion and plantar flexion. Dorsiflexion is pulling your toes to your nose, and plantar flexion is planting your foot down as if you're taking a big, strong step. Protraction and retraction, if you think of your mandible, protracting your mandible, jutting your chin out, retracting it, pulling it back. And then opposition of the thumb and little finger are if they can touch each other. So again, these are important to know because these words are used especially in the physical therapy community, or really every medical field, but physical therapists will use these words to make sure the parts of the body are performing the correct function and moving at the right angle. Then we get to types of synovial joints. They are all seen here in order of increasing movement. These are the 6 classes. So plane joints do not move much. Ball and socket joints move the most. So the plane joint, the articular surfaces are flat planes, and we have short gliding movements. Examples of these are your vertebrae. The gliding does not involve any rotation around an axis. So these are just bones gliding past each other. Gliding motion, the articular surfaces slide back and forth across each other. The angle between the bones does not change, and this occurs in plane joints like between your carpals. Synovial joints, more synovial joints classified by shape is the hinge joint. A great example of this is your elbow, your ankle, your knee, and joints between your phalanges or your fingers because they kind of fit together like a hinge, and they'll perform a flexion and extension, a uniaxial movement. So just one movement, either flexion or extension. Pivot joints will be when a rounded end of a bone fits into a ring that's formed by another bone, plus an encircling ligament. An example of this is the joint between your atlas and your axis, and also the joint between your radius and ulnar when the head of the radius can move around with the help of that ulnar ligament. Condylar joints are egg-shaped articular surfaces of one bone fits into the oval convex shape of the other. So we get a side-to-side movement or a back-and-forth movement. And examples of these are your metacarpophalangeal joints or the radiocarpal. So joints between your metacarpals, the joints in your wrists, and the finger joints. Saddle joints. An example of this is the ball of the thumb, is where the bones of the wrist will fit together in a saddle type structure. Ball and socket joints are easy to think about. Think of your shoulder and your hip joints. So these will be the most movable, where there will be a spherical head of one bone fits into a socket of another. And these charts, you can pause the PowerPoint or my lecture at any time and go through, but this gives you a good kind of summary of all the joints, the articulation components, and then how we structurally classify them. The vertebral column then is formed from 24 irregular bones connected in such a way that a flexible curved structure results. So you can see this is a normal curve in the vertebra. We have a cervical curvature in this cervical vertebra, and then a thoracic curvature, a lumbar curvature, and a sacral curvature. And this type of curvature is important because this allows human beings to walk upright on 2 legs. Because of the curvature, it's allowing them to hold the weight of the body correctly. So these are the curvatures. If there's something wrong, a posteriorly concave curvature is called lordosis. A posteriorly convex curvature is called kyphosis. And then we could have a hunchback or a swayback or a flat back, in different words for that. So these are all abnormal spinal curvatures of this spine. Intervertebral articulations, these are amphiarthrosis, so they're slightly movable between vertebral bodies. And they're diarthroses, so more movable between articular processes. Vertebral bodies are separated by intervertebral discs, and you have different ligaments that help to make these joints more stable. So here we have the intervertebral disc on top of the vertebral body of the vertebra bone, and you can see different ligaments keeping the vertebra strengthened and together. A herniated disc occurs when the intervertebral disc has a little bulge out, so it gets out of its enclosed area, and it pinches or compresses a spinal nerve that's coming off of the spinal cord. This can cause excruciating pain. Herniated discs can be often corrected with physical therapy, stretching, strengthening the back to try to get the bulge back in place, or sometimes surgery might have to be needed. So this is a look at a herniated disc. You can see the bulge of that intervertebral disc on the x-ray popping out. Here's a cervical disc bulge with the spinal stenosis. So it's actually showing how the spine is being compressed there. Probably extremely painful. So you can see that there. Here are your pectoral, girdle, and upper limb joints. And again, you can pause this lecture video to read through this or download the PowerPoint, and do the same with the pelvic girdle and lower limb joints. These are great, just kind of summary charts of the joints. The knee joint, it's diarthrotic hinge joint between your femur, tibia, and patella. It's the largest and most complex joint, so many people have injuries with it. There's medial and lateral menisci. We'll see what those are. And then these are all the ligaments associated with the knee joint. You can have tears in the medial collateral ligament, lateral collateral ligament, but you often hear about tears in the ACL or PCL, which are ligaments within the joint itself. So here's the anatomy of the knee joint. You'll have the lateral fibular collateral ligament on the lateral side connected to the fibia, and the medial tibial collateral ligament on the medial side connected to the tibia bone. And then within the joint itself, you can, I'm not sure if it shows it here, the ACL and the PCL. We'll probably have to look at a different picture for that, but this is the anatomy of the knee joint. Here we go. So here we have the ACL. If you kind of cross your fingers as if you're saying, oh, I'll never tell a soul, you kind of cross your index and your middle finger. That's how your ACL and your PCL are crisscrossed around each other. So this is your ACL in front, and the PCL, posterior cruciate ligament, in the back. You can see a posterior view of the right knee. Here's your PCL and your ACL being in front of it. So a torn ACL is really easy to spot on an x-ray, and it's been highlighted in yellow marking here for you, and you can see the obvious tear. And this is also a front of a knee. The patella isn't shown, but you can see the torn ACL. This is an artist's rendition. So surgery most often needs to go in, obviously, and fix the torn ACL. Osteoarthritis is degenerative joint disease. It's wearing down of the joint space, usually over time, very common in the elderly, also common in athletes who put a lot of pressure on their knees over time, like runners, really anyone who does a lot of pounding activity with their knees. What osteoarthritis does is it wears out the hyaline cartilage. It's the most common type of arthritis. It can affect your hips, your knees, but also your hands and your spine. You can see here on osteoarthritis, there's literally no cartilage left. So it's kind of rubbing bone on bone against each other in that joint cavity, and it's extremely painful. So here's a look at osteoarthritis in a right knee. So this is taking a look at the right knee from the front, and this is showing a replacement knee. So you can see here how in this picture, the right knee, the femur is directly on top of the tibia. So there's no space in between. The left knee looks okay. There's still some space in between. We want to see space. We want to see a joint cavity that's filled with the meniscus, which are pads that separate out the bones. This picture is showing a knee replacement on the right side, and you can see how it just restructured to kind of add in artificial cartilage. It's probably titanium or another substance to create an artificial knee, and this looks a lot better, even more so than the left knee. And that's the end of this slide. Thanks for watching, guys.